Let's briefly look at the treatment for necrotizing fasciitis. So you can see an image of what necrotizing fasciitis looks like. You can see as the fascia is no longer there, and the skin is as well wiped away. You can see the muscle, you can see the purple and dark discoloration of the muscles. So necrotizing fasciitis is a medical and surgical emergency. It is a rapidly spreading infection of the fascia and subcutaneous tissue that causes tissue death, also known as necrosis, severe systemic toxicity, and can quickly lead to septic shock, multi-organ failure, and death if not treated immediately. It is commonly caused by Streptococcus pyogenes, mixed aerobic/anaerobic bacteria, Staphylococcus aureus, and Clostridium perfringens. So, what are the clinical features? Severe pain out of proportion to skin findings, rapidly spreading swelling/redness, skin discoloration, that's purple or black, bulla, which are large blisters, crepitus, fever, toxic appearance, hypotension, confusion. So, pain out of proportion and rapidly worsening soft tissue infection should give a suspicion of necrotizing fasciitis. So you can see the progression of necrotizing fasciitis is it begins with a small blister to a highly severe necrotizing tissue damage. So what is the management of necrotizing fasciitis? First is immediate resuscitation, which should be the first priority. It should follow advanced trauma life support/sepsis principles. Here you maintain airway and breathing, you give oxygen, you do intubation if needed, you ensure circulation, you give aggressive IV fluids such as normal saline, Ringer's lactate. If shock persists, vasopressors such as norepinephrine should be administered. So next is urgent surgical debridement, which is definite treatment. This is the most important treatment. So here immediate surgery should be performed to open affected tissue, remove all dead tissue, stop spread, delay in surgery dramatically increases mortality. Repeated debridement every 24 to 48 hours is often required. Sometimes amputation is necessary. Next is broad spectrum IV antibiotics, which should be started immediately. Begin empirically before culture results. Common regimen include piperacillin, tazobactam, vancomycin, clindamycin. So why is clindamycin given? It is given because it suppresses streptococcal toxin production. Alternatively, meropenem can also be given. Next is intensive care unit management. Most patients need intensive care unit monitoring, which includes continuous monitoring, organ support, mechanical ventilation if needed, vasopressor support, and renal support if acute kidney injury develops. So, what are the investigations to be done? While treatment must not wait, the following investigations can be performed. These include blood cultures, wound cultures, complete blood count, electrolytes, serum lactate, renal function, coagulation profile. Imaging should be done if the patient is stable, such as CT or MRI, which may show facial gas. But do not delay surgery for imaging because this is an emergency. Next is wound care. After debridement, regular dressing should be done. Vacuum assisted closure should be done if available, and skin grafting later to maintain cosmetic appearance. Next is treat underlying risk factors. Common predisposing factors are diabetes mellitus, immunosuppression, trauma, surgery, and peripheral vascular disease. So what are the complications in this condition? We have septic shock, multi-organ failure, limb loss, death, and mortality can be very high without rapid treatment. So the cornerstone of management is early recognition and immediate aggressive surgical debridement and broad spectrum IV antibiotics and resuscitation. So in a nutshell, you suspect this condition early, you resuscitate, you start IV broad spectrum antibiotics, you do emergency surgical debridement, you give intensive care unit care, you repeat debridement, you manage complications, and you do reconstruction of skin. Thanks for listening. Do not forget to like, share, and subscribe for more videos.